So here we are in final part 3 of this discussion of a patient with fever. And so without further ado, we'll jump right back into a little review of the patient's presentation. As we learned, this is a 42-year-old male who had 2 weeks of fever, abdominal pain, tachypnea, tachycardia, hypotension. The patient as well was confused. We noted abdominal tenderness on examination and gross blood on the rectal examination. The patient as well had a history of being treated with quinine for malaria, but no apparent response to that. And then finally, we had obtained a chest x-ray which revealed free air in the abdomen under the right hemidiaphragm. All right. So this helps us with the diagnosis because we think about now putting the case together. The patient has a history of travel, this unexplained fever, progressive abdominal pain, and now evidence of a perforated intestine. So this clinical picture in a patient who has traveled is highly suggestive of enteric fever, in this case Salmonella typhi or paratyphi. Now, Salmonella, in this typhoid, as this illness is known, can cause all of these symptoms. Is frequently associated with progressive fever, abdominal pain, and confusion. Humans are the only source. There's no animal vector. It's not a zoonosis. And the spread is thought to be by water or contaminated food and contaminated with human feces. So in areas where there is poor hygiene or perhaps poor sanitation, this disease can spread readily. There are, on planet Earth, 28 million cases and 200,000 deaths per year. 450 cases per year are documented in the United States. Risk factors for this disease in this particular patient are the travel to South Asia and then visiting of friends and relatives who may have been carriers. So the signs and symptoms of typhoid are an incubation period of 6 to 30 days, an insidious onset, so in other words, the patient may just develop fever without kind of clear symptoms that might help us with the diagnosis. The patient eventually develops fatigue. The fever is lowest in the morning and reaches peak in the evening. Headache, malaise, and then eventually anorexia and loss of appetite are common. Typhoid fever is as well associated with abdominal pain, and this is also progressive. It can be very mild abdominal pain initially, which then of course progresses to the severe abdominal pain associated usually with peritonitis. We can also see diarrhea, but that is also sometimes not a part of the presentation. By the second week, the patient develops a very characteristic rash, as visualized here, called rose spots, and as well the second week is associated with a progression of the prior symptoms. By the third week, the patient is increasingly toxic. Diarrhea at this point is usually present. It's called pea soup diarrhea given its appearance, and the patients can have various presentations, but typically delirium is a part of the third week's clinical scenario for the patient. If the patient presents early on in the course of their illness, they may appear quite well. As we stated, the fever is usually insidious. However, with time, by the time the patient arrives at the third week of infection, the patient is usually quite ill. They may be very dehydrated, and their confusion or sleepiness and lethargy may be very apparent on examination. The patient may have a slow pulse even when febrile, and this is called a paradoxical bradycardia. Most patients, when febrile, are tachycardic, but patients in this particular disease condition may be bradycardic despite the presence of a high fever. The patients may have altered mental status, as our patient did. An enlarged liver and spleen may be noted on the physical examination. And of course, the patient may have an acute abdomen and evidence of peritonitis on examination. The patient, as is the case with our patient, may present with bowel perforation. And bowel perforation and peritonitis in a patient with this clinical scenario, persistent fever, recently returned from an endemic area, should prompt consideration of typhoid. This is a very common cause of peritonitis and abdominal and intestinal perforation in patients who have traveled. Patients may as well not have overt signs and symptoms of peritonitis and intestinal perforation, having just simply presenting with distension. Furthermore, a patient who is confused or lethargic may not be able to relate to you the severity of their abdominal pain, and thus you may underestimate the abdominal examination. The complications of enteric fever are, as we discussed in this patient, intestinal hemorrhage and perforation, as well as sepsis and systemic inflammation and infection. Seen in this particular microscopy slide are Peyer's patches, or lymphatic centers within the intestinal tract, where infections may be initially attacked by our body, but in this case, the typhoid that is able to spread to the Peyer's patches. Initially, it causes necrosis of those lymphoid tissues, which then can be the cause of the intestinal perforation as the intestinal wall falls apart. So diagnostic testing in this case. Patients have a low-grade septicemia, meaning there's low-grade bacteremia, and as a result, blood cultures may not be positive all of the time. Stool cultures as well might not be very helpful during the acute illness. Now, these are important to send because if positive, of course, we'll have our answer, but if negative, it does not rule out the presence of these diseases. Bone marrow culture, not something we typically get on patients in the emergency department or those presenting with acute findings, is more frequently positive. But as I said, this is not often helpful for us in the acute setting. Most often, as the case with our patient, the diagnosis is a clinical one. We see the presence of intestinal perforation, the free air on the x-ray, with the clinical scenario that is very consistent with perhaps typhoid infection. So what is the treatment? Well, fluoroquinolones are an important treatment for typhoid. There is significant fluoroquinolone resistance, and so there are other considerations such as the cephalosporin that can be considered in these patients. Patients who have severe illness may take several days to improve in spite of appropriate therapy, and the patient as well may take a sudden turn for the worse as therapy is instituted. Now, it's very important to consider antibiotic resistance and to consider the location the patient was coming from, because these resistance patterns vary globally, and regional ecology is going to be very important here. It may be important to consider local guidelines for care. So consider the locale where the patient was residing during their travel and determine if what the treatment guidelines are for that particular geographic location. We can also benefit from resources online from the World Health Organization and the Centers for Disease Control and Prevention. Now, it's also going to be important to reassess the patient after initial therapy to make sure that they are taking the appropriate improved course that we expect from them. All right, so in our case, this patient, of course, requires immediate surgical consultation. This is a threat to life. The patient has a perforated viscus and needs to go to the operating room regardless of the diagnosis. So certainly that's important. Many times, resections of the intestinal, of segments of the intestine are important, are indicated in these patients because of the necrosis of Peyer's patches. As well, as we just discussed, it's going to be very important to institute appropriate antibiotic therapy tailored to typhoid as well as the patient's peritonitis and as well to, as we discussed, local resistance patterns. And then, of course, supportive care will be important. This patient is septic. They're going to require supportive therapy for sepsis, and the patient also is delirious. They're going to require supportive therapy for their altered mental status. So, in summary, taking this case from beginning to end, we discussed the initial actions when presented with a fever in a patient with fever with return travel, the initial assessment of the patient, their level of consciousness, the airway, breathing, and circulation exams. We then obtained vital signs on our patient, found that our patient was tachycardic, tachypneic, and hypotensive. Using the patient's history and the sample history, as well as the focused physical examination, we developed a differential diagnosis. In this differential diagnosis, we prioritized those potential diagnoses that could be threats to life. And we used diagnostics to narrow this differential diagnosis to those that had more likelihood than others. We also considered empiric therapy for dangerous diagnoses that we could not wait for the return of our diagnostic information to institute therapy. And then finally, based on our findings, we initiated intervention. In this case, the immediate surgical consultation for the perforated viscus and antibiotics specific to the suspected diagnosis of typhoid. And this concludes the discussion of this patient with fever. I hope this was a beneficial conversation. Thank you very much.